Yeah, what a great presentation. So, chronic total occlusions. Well, I think it's obvious that we know in many trials that drug-eluting stents over the long term still continue to have TLR rates. And especially when we think about CTOs, I mean, we are always used to treat the vessels with very, very long stents. And this is a quite interesting analysis how stents are working, 45,000 patients, and especially when you compare the complex lesions, including also chronic total occlusions, with the non-complex ones, you see that complex lesions have a higher rate of target lesion failure with drug-eluting stents. Well, we already talked about small vessels. It seems to be that drug-eluting stent in small vessels doesn't work so good with very high TLR rates, up to 60% here compared. And that's basically something that we have to address when we think about CTOs and distal landing zones and narrow distal diffuse disease as well. And the TLR rate here from a very nice South Korean study in 70,000 patients was absolutely increased when you use the long stents, or you need to do long stenting versus it was a cutoff evaluated at 40 millimeters compared below 40 millimeters. And also this is a basically predictor as well for cardiac death and stent thrombosis. So when we think about stents, and we also have to think about mechanical conditions that stents have. And one thing that is overseen very, very frequently are stent fractures. So especially when you look at and think about what's going on the ostium of the circ, for example, ostium RCA, we know that their stents can be fractured as well. And if a stent, has the name flex in it, it doesn't mean that it's more flexible. So that can already fracture at quite low cycles in the bench. And another thing is positive remodeling, and this is not always positive. You know the Syntax 2 trial, and this is a case which Simon Walsh gave me, and it was a CTO, and it was perfectly opposed initially with OCT, and perfect result, and the patient came back for a follow-up angiography, and what you see in the proximal LED that the vessel was growing, and the stent was not opposed. So, well, for sure they did a post-dilatation up to 4.5, and how do you deal with that? Well, is that a maze or not? But this is another question. Nevertheless, that can occur as well in such scenarios. So now coming to the idea about how are we treating the CTO and the distal diffuse disease. So this is quite an interesting part, because when you look at that case example, you see that there was put a stent and the whole LED was basically diseased in a way, right? So if you would try to look for landing zone, you would end up for another probably 120 millimeter of stent. But here, well, they did nothing, and you see that the vessel somehow is also growing in the long term. So with LDL lowering and flow and whatever, it might be that you even have a very good remodeling in the distal part without doing nothing even. So Freddy Galassi already analyzed that very early stage and was thinking about how does the vessel, let's say, behave distal, the CTO segment, the occlusion, and what he found basically out that was in the follow-up, especially that when he gave nitro at the follow-up angiography, that the vessel just was enlarged a lot compared to the baseline, and it didn't happen directly after the procedure. So there might be some nitro response after follow-up suggesting a recovery of non-contractile small muscle cells in the intima. So that was a quite interesting idea behind. So there are also registries looking at how are we treating the CTOs and distal the CTO lesions as well, so behind the CTO itself. And there are stenosis up to 50–60%, and you see they were treated and stented and not treated, pardon me. And if they didn't treat the vessels, basically, so a lot of them, when they came back, the stenosis was not relevant anymore. But if they put the stents in, there was a higher TLR rate compared to those without a stent. So now the question comes up, well, should we do a hybrid approach, or can we go with drug-eluting balloon in these complex lesions? We don't want to make the same mistake as we learned from the bioresorbable stents that we already start with CTOs but nevertheless, there are some interesting data out as well regarding CTO lesions. So somehow, if you stay intra-plaque and you have a good plaque modification, not a long dissection, there can be very beautiful examples. Well, it's a case example, and I will bring you some case examples as well. But if we have large dissections, there might be also a downside if you don't cover it. We don't know what it means to have those aneurysmatic formations in long term, but it doesn't look so beautiful, right? So this is also something that you have to keep in mind when you go subintimal and you have a big dissection. Probably in some scenarios the stent might make sense, and this is for sure the intra-CTO segment. So, well, in this cohort, there were like about 67 patients, and 1 and 2 years MACE rate with drug-eluting balloon only was quite not too bad, with 8.3% as 1 year and 16.7% in 2 years. So it might be feasible, and it might be quite interesting to have the concept of intraplaque crossing, and if feasible, that you can do intraplaque crossing, that you end up with DCBs alone. So there are as well long-term outcomes with DCB compared with drug-eluting stent. For sure, no randomized trials, but there is no big difference in this cohort when the operator decides what is the better strategy. In our large registry, we also wanted to look a little bit more into it, how the DCB catched up in the EuroCTO's registry, and we have the 45,000 patients in this trial. And here you see that in the last years, there's a big increase of DCBs going up to 15%. So we saw that DCB was associated for sure with shorter stents and lower contrast volume, but as well, and that's important, lower pericardial tamponade. So probably in some scenarios with the CTOs, we were not so aggressive in plaque modification, and that's probably advice in general. So we know that in small vessels it seems to be feasible to do DCS only, and the larger vessels seem to profit more from the drug-eluting stent, as we know for now, and we have good outcomes now that we are non-inferior, but is this translated to the CTO community and the CTO vessels? So we have to wait. I think Paul Knappen will give us as well his insight of the CTO trial, where he makes a comparison, a randomized trial about that. So I will finish with some interesting examples, like the speaker before me. This is intraplaque crossing, 56-year-old male. And when you have such an angioplasty result, you also can do a DCB treatment, right? It's will stay open. And when you look at the IVUS as well, there is almost no remaining dissection, 6-month follow-up, right? You can give the patient, you try to get the LDL down. So this is a soft plaque here. And maybe he doesn't need any stent for many, many, many years, right? And still, he can go to surgery if needed one day, but I don't think he will ever see a surgeon. So this is a 43-year-old male. He was a very interesting, smart guy from Kazakhstan, and he wanted to keep a completely stent-free approach because he was running to multiple doctors, and the surgeon told him, well, we don't know how we can deal with this distal LAD. And well, I show you the story what we have done. We crossed the LAD and also the diagonal branch, and this is what you get after the initial result with DCB. It doesn't look so good. We treated the PDA, intermediate branch, LAD, diagonal, everything with DCB, completely stent-free result. The patient came back just a couple of weeks ago, 6-month follow-up. Well, I'm happy with this distal result. I mean, it's not too bad. He felt very, very good. But nevertheless, I saw that the diac, right, and as proximal LAD probably need further treatment because he's doing exercise and everything. I don't want to get them in ischemic event. So I used a cutting angioplasty there, right, and look what the cutting is able to do. This is not a large dissection. It's a focal dissection. It's like a stent-like result. And you put the DCB there. I did the same on the diagonal branch and one distal. And yeah, at the end, you will end up with a quite nice result in this multivessel disease in a young patient, and you can keep him away from drug-eluting stents and probably surgery for many, many years. So that works good in young patients, and also in more complex scenarios where you have to use dissection reentry techniques. Here's a retrograde case, already had some stents in the LAD and circ. This is a huge RCA as well, and was treated in Egypt, and they are quite open to drug-eluting balloons because they have so many young patients there. And this was a retrograde approach, as you can see, with reverse card, 43 years old. And I mean, it needs experience, right? Because I was absolutely happy with this result, and I got a lot of criticism from the auditorium, especially also from European people, because there's an ostial dissection, right? But well, as we do a lot, and we saw a lot, and we know a lot about that, at least this ostial dissection, and if there's no stent, it does make stent thrombosis, right? So I said, we keep that vessel, and this is the 6-month follow-up. The patient's happy and doing well. So. It's working. I rarely see any occlusions there. And from the CTO registry, we have also seen that it seems to be safe regarding the primary outcome. For sure, we need more long-term data. And in general, we can say that drug-eluting stents are safe. We know that, have low event rates, and once guided by intravascular ultrasound, especially when we think about large vessels. And we know that the DCB failed to demonstrate non-inferiority in the randomized recharge-free trial, but was non-inferior to DS in small vessel and basket small and in the de novo solution. And the de novo solution is showing us a similar trend that below 3 millimeters, it's a perfect idea to do drug-eluting balloons. So the combination with drug-eluting stents and DCB, especially for the small vessel disease, is very promising, and we need for sure more data to confirm this strategy. Thank you very much.